well, it's good morning right now, where spring has kind of come, but I suppose it's midday and maybe even later in the day where you are. So I will be doing a kind of introduction to the World Health Organization, and it's a kind of brief one. Um, David Legg is here, so I think that's great because he really is the guru on this topic. And so, David, I'm hoping that where I've missed things, maybe misinterpreted, or there's nuance that you want to add, that you'll feel free to do so. So if you want to jump in during the presentation, or if you prefer after to comment on some things, then I'd really welcome that. I'm a member of the team that organizes the Global Health Governance group and also runs the Watch. So Pao spoke about that. Hi, Pao. And today we're looking at the institution itself, meaning the World Health Organization, and giving some background on what it is, how it functions, and maybe some key issues for us to consider as health activists. So that's the introduction. I'll share my screen. Maybe if I could be allowed to share my screen, that would be helpful. And then I don't know if anyone has any questions at this stage. No? Okay, so then it seems like we are ready to go. Okay, is my screen visible?
Yep.
Yes.
Yeah. Okay, great. Okay, so like I said, it's very much an introduction to WHO. So it will be maybe a bit of a whirlwind tour. I'd like to focus on four things: the structure of WHO, its functions, some of the power dynamics at play in WHO, and then key moments in its history. There will be an exercise on WHO DGs that you will do in your group work, and I believe you've been allocated a DG to focus on. So I will not be covering that in the presentation itself. That I think is very much a part of the workshop or the session for you to focus on and to lead the discussion. And maybe when you're doing that conversation, you can link back to some of the things that I've mentioned in this presentation. So let's think about WHO in historical context. It is one of the oldest intergovernmental organizations in the world. So intergovernmental organizations have governments as their members. And WHO was established formally on the 7th of April, 1948. That's when its constitution came into force. But there were a series of health-related structures that tried to look at the international or transnational determinants of health that existed even before the World Health Organization. So I think maybe the most important series of meetings around, let's say, international health were the International Sanitary Conferences. That's what they were called. They took place from the 1850s onwards, mostly in Paris, but in Europe for the main part. And these sanitary conferences were a response to the fact that through empire and trade, the increased movements of people and goods, the world was also experiencing the increased movements of pathogens and disease. And so, of course, this is something, I think the first sanitary conference was in 1851. Obviously, this is a problem that even predated the 1851 sanitary conference. And that's reflected in the fact that many of the kind of international cities at the time, so if we think of Venice as a very early commercial trading center in the sense of a global trading center, those global trading centers that had experiences of plague disease, for example. And so what had happened prior to 1851 is that different cities or different regions would have their own kind of quarantine procedures or epidemic infectious disease control measures. And the series of sanitary conferences were really aimed at standardizing across the world the responses that governments would take in containing diseases, specifically infectious diseases. So that we can think of as a kind of precursor to the international management of disease. And later on, we have the World Health Organization being established. maybe one thing also to mention here is that these international sanitary conferences, sometimes the understanding or the conception of the project was that these were conferences aimed at protecting Europe from diseases of the outside, from diseases of the South. So it was also connected to an understanding of the colonies or the rest of the world as sources of disease and threatening to the health and well-being of the North. The second kind of big international structure that exists before the World Health Organization is PAHO, the Pan American Health Organization. And that was a structure that was established to manage transnational determinants of health in the Americas. It is still a structure in existence today. And so it kind of operates alongside the World Health Organization. Then after the Second World War, towards the end of the Second World War, we have the establishment of an interim body that kind of replaces the sanitary conferences and PAHO. It's the precursor, the immediate precursor to the World Health Organization. So there's maybe a 2 to 3 year period where this interim body is functioning until such time as sufficient member states ratify the WHO Constitution. And as I mentioned, that happens in 1948. And really its mandate is meaning the World Health Organization, its mandate is to ensure that people across the world are able to benefit from the right to the highest attainable standard of health. So this means that WHO's mandate is not only to ensure that there's absence of illness, so it should in fact do more than that. It should also ensure a full sense of spiritual, physical, mental health. And so that's the ideal. What we'll see is that often the organization has focused on very narrow kind of biomedical conceptions of health that actually are aimed at managing illness, but struggle to deal with the wellness and health promotion part of this mandate. So as I've mentioned, WHO is the organization of note in the post-1945, the post-World War II global order, responsible for leading and coordinating global health responses. So that's officially its mandate. We'll speak a little bit more about the fact that actually in some senses that a role of WHO as the lead authority in the international health space has been challenged or displaced by other actors. And in its own words, if you go to the WHO website, it describes its own function as working worldwide to promote health, keep the world safe, and serve the vulnerable. So in its current articulation of how it's supposed to do that, WHO has focused on 3 main kind of projects. The one is UHC, which it translates into universal health coverage. So that project in WHO's telling or description of it is concerned with making sure that people can access the healthcare services they need without enduring financial hardship. So it's very much a program focused on access to biomedical services. It's focused on making sure that they're affordable to the people, the households, and the patients seeking services. But the WHO's UHC agenda is very agnostic or neutral about whether those services should be provided by strengthening the public system or simply giving more people access to private providers. There's a lot of emphasis in the universal health coverage discussion on access to insurance. So some people will say, actually, it's more focused on promoting access to healthcare services by expanding access to health insurance. But that is, in simplistic terms, how UHC has been operationalized by WHO. And of course, there's a critique. So from a PHM perspective, we would say, oh, this seems more a conversation about a financing model to access healthcare services. It's not necessarily a discussion about universal access to care, and care as entailing both preventative care and emphasizing not just curative care at the kind of high-end hospital level, but also comprehensive health promotion services at the community level, right? So through comprehensive primary health care. The second thing that WHO is focusing on increasingly is health emergencies. And so this is kind of a stream of work that's a direct response to the historical conjuncture we find ourselves in. So of course, one type of health emergency that's very close to us or present in our minds would be the COVID-19 pandemic. And so there is a sense that WHO is trying to figure out how to monitor the threat of infectious disease outbreaks, how to respond to that in order to contain an outbreak, and then if it can't contain it, how to manage or govern a pandemic so that people have equitable access to the healthcare services and technologies they need. So that's one kind of health emergency that the organization is responding to. But increasingly, if you look at its reports, it's also emphasizing that health emergencies related to climate disasters and health emergencies related to war and conflict make up actually huge areas of work for its workforce. And if you listen to the HR, the human resource reports of the World Health Organization, it's clear that this kind of work is taking its toll on the Secretariat staff and also field staff, but also that it's a reality given the climate crisis and the kind of volatile geopolitical world we live in at the moment, that this pillar of work will probably expand. It's a kind of crisis response pillar of work. And what WHO has found, especially since the conflict in Palestine, is that health workers are no longer seen as kind of people to be protected from conflict, and that actually health workers themselves are being attacked and made vulnerable to conflict situations, and health facilities being framed as political, not technical, and that language is a little bit problematic, but as kind of political actors, and that makes them vulnerable to political violence. The final pillar of the work that WHO focuses on in its current kind of period of the last 3 to 5 years has been well-being. So if you look at the bottom bullet on the slide, its focus on well-being work is kind of trying to grapple with the fact that how we think about health has shifted. So increasingly, there's a realization that you can't really ignore the social determinants of health. And those social determinants are not only a variable, like does someone have a high school education or not, but also those variables, those determinants are connected to political, social, economic processes. And so that's what I mean by social determination of health. So there is a growing kind of awareness that the organization maybe needs to focus on these bigger structural processes that end up producing variables like lack of access to education, lack of access to housing, and to look at how those processes influence the determinants of health. Recently, so let's say in the final few months of 2022, the WHO also opened up a new unit within the social determinants of health work stream, which focuses on the commercial determinants of health. And that unit focuses on how commercial actors, so for example, transnational corporations, but also smaller firms, through their actions impact health outcomes. So it would be something like a processed foods company like Nestle, it might be a pharmaceutical firm that protects its IP, it might be an agricultural firm like Monsanto that sprays glyphosate that is carcinogenic. So there is a work stream in WHO that focuses on these kind of structural processes. It's not particularly well funded, but it's there. And in fact, the new report on social determinants of health is supposed to be published this year. It's not yet been published, and it's October, so it's not clear whether that will actually happen. WHO is a technical body, which means that its member states have said it should give technical advice based on facts about how health should best be promoted. Because of that, it has a biomedical focus. But one of the things to remember is that historically, but again, in this volatile geopolitical context, that technical focus, something that seems factual, might actually also kind of activate political competition or ideological competition between states. And so even though officially its function is to give technical advice, that technical advice sometimes is seen by member states to also be political. So one big example of that would be at the executive board meeting this year. There was a report tabled on sexual and reproductive health rights for adolescents, including adolescent girls. And that was based on best practice clinical evidence. Then the Russian Federation objected to the report and said, well, actually, in international law, there's no right to sexual expression for adolescents, and this is a political intervention that the organization is making. Afro region endorsed some of the sentiments in the Russian Federation statement. And then they became, it's generated a big debate, right, about whether WHO is overstepping its mandate. And other countries, for example, Canada and the US, the EU said, no, this is technical advice. It's supposed to promote health in this age cohort. It's factually based, and it's not political. So that's just to flag that even though there's a biomedical focus and a technical mandate, these things are also always extremely political. In the final bullet, the final two kind of clauses, indigenous knowledge systems and planetary health, I've included that to kind of acknowledge that, in fact, WHO, it has these functions that are kind of hard and technical, but over time, it's also tried to accommodate alternative worldviews. So for example, in the area of medicines, it has acknowledged that there are allopathic medicines, I think that's what they're called, but non kind of Western medicines. So both medical products, but also processes, healing processes that should be acknowledged and officially acknowledged in WHO guidelines on how to use them safely. And so there is a sense that WHO as an agency of the whole world, and not only certain kinds of knowledge perspectives or worldviews. There is a sense that the organization is trying to embrace that dimension also of its work. And then finally, increasingly because of the climate crisis, it's emphasized the importance of planetary health, which means that it's emphasized also the relationship between human and non-human health. So the non-human side might be animals, for example. So in its work on One Health, it's looking at pathogens that exist in a number of species, not only humans, and how those pathogens might move from other species to humans and cause health complications. So that might be a pandemic, but it might also be like a parasitic disease, for example. So those are some of the functions I thought I would highlight. We can speak a little bit about the structure of WHO. Its headquarters are in Geneva. And so this is a small section of an organogram available on WHO's website that explains the structure of the headquarters. So there's obviously the Director General, which gives direction to the overall program of WHO. And then you'll see that the kind of big layer at the bottom of the organogram on the slide, there's a lot more that goes with it on the original, but that gives you a sense of the different clusters that WHO focuses on at HQ level. So a lot of it has to do with, or one big section has to do with kind of the operational side of the organization. So how do you run a big intergovernmental organization? And part of that conversation is a conversation about how you finance the budget of that organization. Then there's a cluster of work around information, so data analytics, and how the chief scientist, who now is Dr. Jeremy Farrar, he used to be at the Wellcome Trust, now is at WHO. How does that information get used to actually do health promotion interventions? There's a huge cluster around universal health coverage, UHC, and that focuses on infectious diseases, but also NCDs, so lifestyle diseases, as they used to be called. And then there's a cluster of work, excuse me, on access to medicines, and a final kind of cluster that's very fluid at the moment, I would say, on health emergencies. So both pandemics, but also climate and conflict related. So HQ traditionally has directed the programmatic work of the World Health Organization. There are 6 regional offices, and they do a lot of implementation work. And there has been an ongoing conversation about maybe giving the regional offices more autonomy and power. So it's been discussed in the last 2 executive board meetings. There is a concern amongst regional offices that that should not be done unless their budgets are also expanded, so they actually have the capability to implement the plans that they come up with as a little bit more autonomous units in the organization. And then there are 150 country offices globally. So I mentioned before that WHO is a member state organization. So at the moment, it has 194 member states, and they are the ones. So WHO is the Secretariat in Geneva is supposed to take its instructions from its members. The members have membership fees that they pay, and those membership fees are supposed to finance the budget. Those membership fees are known as assessed contributions in WHO language. Over time, they've declined and actually made up a smaller share of the budget. So I think at the moment, maybe they make up only 20% of the budget of the organization, which means that the organization has to find money from elsewhere, and we'll speak a little bit more about that. But these member states come together in various structures to give direction to the work of the Secretariat and also to hear the Secretariat's reports on its programs that it's been implementing and its proposals for new programs. So the big forum, or the biggest forum, which is kind of like the parliament of WHO, where member states gather each year, is called the World Health Assembly. That usually happens in May of each year in Geneva. And so countries send delegations, usually from the capital. And these delegations then hear progress reports, proposals for new projects. They might vote on resolutions, but it's like a sitting of the General Assembly of the WHO. And that's the highest decision-making body of the organization, of the institution. However, the issues that get tabled at the Assembly in May are kind of pre-discussed in January at the Executive Board meeting. So the Executive Board meeting is a smaller structure, and it has representatives from all the different regions. There's a regional balance, and membership in that Executive Board structure rotates amongst different countries. And so that's really the structure that debates the agenda items, debates the reports, gives advice on what should be changed before the documentation goes to the Assembly. It is a smaller meeting, so often not all countries can send big delegations. Sometimes, a country might send only one person. So there was a time I participated as a watcher in, I think, 2018, and Eswatini was a member of the Executive Board, and it had one delegate. Other delegations like the US will have much bigger teams, so members in the teens, right? So that's the EB, but even the EB has a smaller subcommittee called PBAC, the Program Budget and Administration Committee, and that subcommittee meets before the Executive Board meets, and they discuss proposals in even more detail. So that's kind of the information flow. PBAC prepares documentation for the EB prepares documentation for the World Health Assembly. At both the EB and the Assembly, civil society organizations that are in official relations with the World Health Organization can be present in the meeting and listen to the proceedings. They can make very short statements. That's not the case for PBAC. So PBAC is a closed committee, and civil society is not entitled to be present and witness those proceedings. The other thing that's important about WHO is that sometimes they have kind of temporary processes that run. So for example, at the moment, there's a temporary process for negotiating a pandemic accord, and that's managed by the INB, the Intergovernmental Negotiating Bureau. It had a temporary process that ended in May of this year to do revisions on the international health regulations. And those are regulations that are in place to manage disease outbreaks and public health emergencies of international concern. So like the SARS and MERS outbreaks of the early 2000s, the Ebola outbreak of 2014 in Central and West Africa. And IHR also is supposed to be the kind of key instrument to respond to COVID, but it was found to be lacking. And then a final stream of work that's ongoing at the moment also is on falsified and substandard medical products. So that's a bit about the structure of WHO. One of the things that I think is really important for us to take into account is that the organization is a member state organization. And so that has implications for how it functions, because obviously not all countries were able to be members um, at different points in history, right? So what do I mean by that? Very concretely, when WHO is brought into being in 1948, many countries in the world, especially countries in the global south, um, are not autonomous states, they're not sovereign states, they are uh, inserted into these huge empires, right? So colonialism means that most of the countries in Africa, Asia, parts of the Middle East are not eligible for World Health Organization membership or for membership in any other multilateral institutions, so the UN or an international financial institution like the Bretton Woods institutions. It's a little bit different for Latin America because they gained independence much earlier than Africa and Asia. But certainly the kind of thinking about how to manage infectious diseases in particular um, emerges during a period where there's empire, where the priority is to protect the health of the imperial centers. Um, it's also a period during which science is understood or is practiced in a way where there's a conception of people as falling on a hierarchy of evolution. So even medical science sees people that are racialized as Black, brown, and so on as inferior. And so I think one of the things that we need to think about is that this baggage is part of a kind of ideological structure that's functioning at the time when WHO gets established, but that it gets challenged during a fuller period of multilateralism that emerges in the 1960s and 70s. And I say fuller period of multilateralism because what happens then is that the so-called third world, Asia and Africa in particular, so there's a kind of third world, as it's called at the time, emancipation project. Many nations in Asia and Africa step onto the stage as autonomous, self-governing nations after having fought against the imperial overlords, if you want to call it that. And because they're now sovereign states, they can become members of multilateral organizations with full voting rights. And so that allows them to change the agenda and the emphasis in the programmatic work that takes place in these organizations. They don't have as much political and economic leverage as the richer nations. So when you join, for example, WHO, your assessed contribution, your membership fee, is tied to many things. One of them is tied to the size of your economy. So if your economy is smaller, then you can contribute a smaller membership fee compared to like the US, for example. So obviously the economic leverage you have is less, but the advantage is that as a member state organization, your vote counts equally to bigger countries. And so the third world nations, because of the size of their voting bloc, actually has a tactical advantage in organizations like WHO if they vote as a bloc. So that's how they can shape the programmatic work. So this happens with most liberation struggles being more or less, let's say, won by 1974 with the liberation of the Portuguese colonies in Africa, South Africa and Namibia, still not. But one of the complications is that as third world states step into independence, the global economy is becoming much more globalized. Globalized in a way where actually the lead actors in the global economy are not just nation states any longer, but also transnational corporations. And so that's a big tension because these multilateral institutions are designed so that states can come together and decide how states should act. There isn't necessarily at this time a big focus on how corporations should act. And again, this is something that third world states struggle with when they achieve independence. And they say, actually, in multilateral institutions, we should make a program of action that disciplines transnational corporations because we have political independence, but we don't have economic independence. And because we don't have economic independence, we don't have the budgets we need to provide schools and healthcare and social support systems. And so what happens in the mid-1970s is that the newly independent nations push for and succeed in securing a declaration on a new international economic order in the UN General Assembly. And one of the key components of this new international economic order that they're advocating for is for states to have control, sovereign control over their natural resources, to be able to discipline the transnational corporations that operate in their jurisdiction, to be able to benefit from conditional financing, so cheap loans and tech transfer, so that they too can industrialize. And that declaration is important because it really tries to restructure the global economy so that countries can trade on more equitable terms. And so that these development divides that we see emerging in the 60s and 70s get narrowed. That's the plan with the NIEO, the New International Economic Order Declaration. That happens in 1974. It's adopted but never really implemented. And in 1978, the conference that's pictured on the slide takes place. It's called the Alma-Ata Conference, and it happens in the USSR. That's a conference on public health, or on health, the right to health, how to achieve the right to health for all. And it's a huge conference for many reasons. One is that it has representatives of communist and capitalist states, and that these states actually managed to agree that countries should be able to use whatever economic system at national level they think will best promote health outcomes that are equitable and just. They also agree that inequalities in health within and between countries are not defensible and should be eliminated. And they also agree that one of the things that's important to eliminate these inequalities is acting in accordance with this new international economic order that was embraced, at least in principle, in 1974 by the UN General Assembly. The Alma-Ata vision also says that what we need to do is focus really on health promotion and prevention. So primary community-oriented primary healthcare is very important. We shouldn't have health systems that necessarily focus on curative care mainly. And this is hugely influenced by the preventative healthcare models operating in China and the USSR at the time. And the other part of the Alma-Ata Declaration that's important is that it says, health really should be something that's mainstreamed in all the different sectors of governance. So when we're thinking about macroeconomic policy, we should be thinking about its health impact. When we're thinking about housing, when we're thinking about agriculture, not just when we're thinking about hospitals and clinics, but all these things should be taken into account at national level. And even in our transnational relations, so trade agreements, right? That health should be present and a kind of key reference point in all of these dynamics. So this is important because the Director General of the World Health Organization is really open to this vision, both the one set out in the NIEO and Alma-Ata of comprehensive and community-oriented primary healthcare. And we'll speak a little bit more about how that goes south. So it's in principle, there's a DG that supports it, but there's a contest within the organization about whether that's really how the organization should work. And then I want to speak very briefly just about the present moment that we find ourselves in. So as globalization deepens from the 70s into the 1990s and 2000s, it generates huge inequalities in wealth. So not only between the global north and south, but what we see in the global north are that transnational corporations become hugely wealthy, sometimes more so than states. That some transnational corporations like Microsoft, for example, establish subsections or entities related to them or financed by them. So charitable foundations in particular. So Microsoft generates a lot of wealth for its CEO, Bill Gates. Bill Gates then uses that wealth to establish a charitable foundation, the Bill and Melinda Gates Foundation. And that charitable foundation uses this privately accumulated money to shape the agenda of global health from about the mid-2000s onwards. We also see in the wake of, for example, HIV/AIDS activism, civil society organizations that have the public interest at heart become transnational actors and very active in also trying to shape the agenda of the World Health Organization and other multilateral institutions. And of course, we also see public-private partnerships emerge with the rise of neoliberal economic globalization. We see part of the ideological infrastructure of that project is this idea that states should do what they're most efficient at. And one of the things this ideological frame says they're inefficient at is providing social services, healthcare services, and so on. They should leave it to private sector actors. What that means is from the 1990s onwards, there's this big emphasis on PPPs, public-private partnerships at national level, but also at the global level. So you have partnerships like the Gavi Alliance that promotes childhood immunization in low-income countries. And basically what's important in terms of the power landscape in that final bullet is that you have lots of actors, many of them non-state actors, some of them aligned with for-profit industries and some of them critical of those industries. But you have all of those actors from the 2000s really onwards having a big seat at the decision-making table. Some have more influence, so charitable foundations have a lot more influence in shaping the global health agenda within the WHO and also other forums, others less so. But what we do see is an expansion of the actors in these multilateral institutions to include both governments and also non-state actors. Okay, so I think I'm kind of running out of time, so I'll spend another 2 minutes on this slide and then hand back if that's okay. One of the things that the World Health Organization does at the Secretariat level in Geneva is propose a program of work to member states, to its constituents. And so the most recent program of work was tabled in May of this year. It was the 14th General Program of Work, and it's supposed to run from next year until 2028. It's basically where the WHO says, this is what we plan to do. Do you think it's a good program of work? Are you happy with us proceeding? And then the member states usually endorse the program of work, partly because they've seen draft versions of it before it even gets to the assembly. So one of the things that's said about the current program of work under DG TEDROS is that it's a program of work that has seen extensive public consultation. So this is something that's supposed to make it very distinctive compared to others, and that's seen by civil society actors as a good thing. Some of that consultation has taken place in the context of a new structure the World Health Organization Secretariat has established, which is the CSC, the Civil Society Commission. It's a kind of forum for non-state actors who want to engage in consultations with the World Health Organization. So you apply to become a member of the commission. But very strangely, the WHO Secretariat selects the leadership of that commission. But it's one line of communication that it's opened, and generally communication and consultations with the Civil Society Commission happens exclusively with civil society. So it's not like civil society gets to speak to member states, for example. Within the context of the commission, it's more civil society speaking to WHO Secretariat. So there's also a kind of question about how influential it really is. The current program of work has these 6 strategic objectives that's listed on the slide. So there's a big emphasis on climate change. There's a big emphasis on intersectoral work, so making sure that health is at the center of not only the health ministry's work, but also the work of other ministries. And that might include, for example, trade and health, but also more and more something like agriculture, because that's seen as an area of work where pathogens that emerge in, for example, the food chain. So if we're talking about microbial resistance, that would be in big farming kind of setups, pathogens jumping into humans, but also, influenza viruses, for example, that emerge in farm animals jumping into humans. So there's this emphasis on other sectors and their impact on health. There's also increasingly, and it's not necessarily listed in these bullet points, but there's an increased emphasis on non-communicable diseases. There's a lot of worry about the silent epidemic of things like cancer, hypertension, heart disease, diabetes, and that's a big focus of the new program of work. There's also a big focus on mental health. So in response to something like the climate crisis, in response to increased wars and conflict, but also a big conversation happening about mental health in adolescents and the impact of digital engagement on adolescent health, social media, and so on. So increasingly, mental health is a big focus in the program of work. Health spending, catastrophic health spending, so kind of protecting households, but also countries from catastrophic health spending is a big area of work for this program of work. It tends to focus on access to insurance. Of course, there are other ways to to insulate countries, for example, from kind of the catastrophic impact on health spending. So that might be, saying to international lenders, could we write off some of the debt that these countries have, because it means then they could actually spend more of their budgets on health instead of less. But those kind of structural processes are largely outside of the general program of work. And then the other thing that's also present in this list of bullet points is that there is increasingly an emphasis on health risks. So that often translates into pandemic prevention, surveillance, and outbreak response. I think just to summarize the slide, the image on the slide, one of the things that's really important is that this general program of work has to be funded. So there needs to be a budget for each of the projects or pillars under the GPW. And that's a big challenge for WHO. Since the 1990s, the bigger states that have the biggest assessed contributions have pulled out from funding WHO as robustly as they should. And part of the rhetoric was that they didn't want to contribute money to a dysfunctional and inefficient organization. One can debate whether that was really the reason why they defunded WHO, but it has had the consequence that member state contributions has declined over time. They make up about 20% of the total budget. And now a lot of, actually 80% of WHO's budget is funded by voluntary contributions. So it's voluntary in the sense that if I was super wealthy, I could volunteer to give them 5 billion. But there's no way for them to predict whether they'll get the 5 billion or not. It's just, I wake up one day, if I'm Bill Gates, and I say, I want to contribute so many billions, but I'd like you to use it for polio eradication. So voluntary contributions are problematic because they're unpredictable, but also they're often tied to specific health issues. And those health issues might not be WHO priorities, they might be the priorities of the funder. And so increasingly, the organization has had to deal with those complications. Its response, which it initiated this year, was to do what it calls an investment round in WHO. So it's seeking for investors, private sector, governments, whoever wants to give voluntary contributions to pledge voluntary contributions, but also to say, I'm giving you money, it's a voluntary contribution, but I'm not going to specify what area of work you should allocate it to. You can just use it for your base budget. So it's like free money, untied money. And again, that's seen as something positive by the WHO Secretariat. From the outside, it raises questions about private sector influence shaping the agenda. So even if a voluntary contribution comes and it's officially untied, one can ask whether unofficially there's been a conversation that suggests that certain things should be financed, or even if that conversation hasn't happened. Let's say, for example, the Kingdom of Saudi Arabia gives a huge voluntary contribution untied. It might not specify what it should be used for, but WHO might feel like maybe it's not wise to spend a big budget that year on issues that upset the Kingdom of Saudi Arabia, right? So it might be that maybe you're not as vocal on sexual and reproductive health rights. That's just an example. I'm not saying it's happened. I'm saying that's a complication that emerges from the current funding model. So I'm going to leave it there because I think I've spoken for a lot of time. I wanted to speak about significant moments in WHO history, but I think because of the time that I've spent, I'll leave it here and then hand back to David, and he can kind of judge what he'd like to add. Thank you.
Thanks, Lauren. Dear people, you've just heard a magnificent presentation about WHO. It's really an exceptional overview of where we stand. I wonder how we stand in terms of questions, though, for Lauren. Questions or comments? If you could put your hand up using the react button. Is it the react? Yeah, react button to put your hand up to ask questions. We'll just have 5 minutes perhaps before we go into our groups to see how we stand.
David. Yes, me. I want to ask some question.
Right. Yeah, go.
Yes. Thank you. Hi, Lauren. I'm Nurbai from Indonesia. Actually, probably I missed the explanation about what is the structure or the delegation or the common structure between the director general and the regional director, because it is not mentioned in that structure. And as you mentioned that only about 194 countries that involved in WHO. So what about the consequences of this of those countries who doesn't involve in the WHO? And I think that's a good news that, as you mentioned, WHO also acknowledge the traditional knowledge of the indigenous people, because I know that they are the one of the most vulnerable group in this group. But nice to hear that WHO also acknowledge that traditional knowledge. Thank you, Lauren.
Thank you. So there's a question about regional officers and then a question about, remind me?
I don't think the second was a question. It was just a commendation, appreciation.
So in terms of the regional officers, they're not completely autonomous. So they're supposed to focus on the mandate that's set out in the general program of work. But often the regional officers have the power to work on specific issues that are important for the region. So for example, the Africa Regional Office might focus on HIV/AIDS, right, as a kind of key vertical program. That might be less of an issue in the regional offices in the Americas. Food insecurity for some regional offices. So EMRO, it would also be war and conflict, migration, and health. So the regional offices have the space to focus on these specialized interventions. They also have their own regional meetings. So after the World Health Assembly in May, the ministers of health in each region will meet and have their regional meetings and kind of flag things that are consistent with the HQ policies, but that they might want to focus on a bit more. So in the Africa region, for example, last year, they had their regional meeting and the African ministers of health said, well, actually, we want to adopt a resolution on medical manufacturing in the African region because that's an issue that we want to push, because COVID showed that this was something that really hurt us, that we didn't have the capability to produce medicines. Like I said, there is a debate about whether you want to give, within WHO, whether you want to give regional officers more autonomy and control. In interventions, the officers from Latin America and Africa have pushed back a little bit on that, because they've also noted that in terms of funding allocations, what they've been allocated is too small to do any meaningful kind of autonomous regional work. Yeah, yeah. Please, David, go ahead.
I just want to make a couple of points about the regions. In 1946, 7, 8, when the Constitution was being written, the member states who were there, as Lauren has said, were dominated by Europe, North America, and Latin America. And it was the PAHO countries refused to give up the independence of PAHO within WHO. And the consequence of that has been that the Constitution was structured around the independence of PAHO, because there was nobody there from Africa or from Asia because of the colonial situation. The regional officers have got a very funny regional director has a very funny relationship with his ministers of health, because they vote for him. And if he offends his or her ministers of health, they won't vote for him or her. And if he gets sacked or loses his or her job, he won't get a job in WHO. So it's I won't say it's corrupt, but it is a situation of where the WHA, the headquarters, doesn't have as much authority as it perhaps could have. WHO is unique among intergovernmental organisations because of this regionalism. Nothing's going to change it, but from a PHM point of view, we want to hold those regional committees accountable for what they do. So it's an important feature of PHM's work in this area. Sorry, I'm going on too long. Deepika's nodding when I said I was going on too long. Any other questions? Paul.
Thanks, David, and thank you very much, Lauren. That was as David said, that was a magnificent description. I just have one query, and that is with increasingly severe climatic events, such as, for example, the recent unprecedented floods in Nepal. Is there any movement within WHO to actually have the capacity to be able to address those kinds of really severe and increasingly frequent climatic disasters, and how does that sit with the adequacy or otherwise of resources? Thank you.
I'll take a stab at it. I think WHO is struggling with whether it wants to be so I think it's struggling with whether it wants to have the capacity to respond to disasters itself, which historically that's not been the case, or whether it wants to be in a position to coordinate. And I think it goes back and forth between these two things. I think in terms of budget and human resources, if you look at the documentation, but also if you listen to the human resource reports, it's clear it doesn't have the capability to intervene. People are overstretched. And what staff it has at a regional level or on the ground, the situation seems to be that people are dealing with kind of stress, burnout, but also very precarious contracts. We spoke a little bit about it in our subgroup last week. So there's an acknowledgement that it needs to do something, but that it's overstretched, but also that the burden of these kinds of diseases are taking up an increasing share of its portfolio of work. When you look at infectious diseases, for example, pandemics and so on, the organization, if we think about the response post-COVID, to me seems to be stepping back from wanting to do a kind of active response. So what do I mean by that? For example, there was a request by the Africa Bloc in the context of the pandemic accord discussions that WHO manage a pathogen database, so that if pathogen sharing does happen, let's have a database managed by WHO as a member state organization. It's kind of in the public domain. It can then, have terms of use. So you must register who you are. You must explain what you'll use it for. You might pay a small membership fee. WHO rejected that. It said we don't have the capacity to run a pathogen sharing database. It must be done by another agency, maybe affiliated or guided by WHO using technical advice. But its response was, no, we don't want to do that. So to me, it kind of indicates that so this is me personally, I'm not saying it's a PHM, but it feels like it's kind of abdicating. So it's gesturing towards being involved and being the lead authority, but it's kind of not. It's willing to act as a technical advisor for other entities that do that work. Maybe, I don't know, David, if you want to come in.
Yeah, I do. I'll tell a slightly different story. Several of the directors general have raised the question about having an intervention capacity, an emergencies capacity, and it was always opposed by the US. In fact, Dr. Chan in 2011 made a big thing about the need for an emergencies capacity, and the US refused to countenance it again. And it was only with Ebola that the member states finally agreed. So it's not, and just to make a segue from there to the issue about pathogen sharing. Pathogen sharing is intensely sensitive because of Indonesia, Nurbaya. Indonesia, who said to the big pharmaceutical companies, we won't give you pathogens to make vaccines unless we get access to them. And this is very closely related to the Nagoya Protocol of the Convention on Biological Diversity. And the rich countries, in particular the host countries of the big pharma, do not want to see pathogen sharing. So it's when Lauren says WHO said they couldn't do it, I presume you mean the Secretariat said they couldn't do it. But my guess would be the Secretariat had been told, if you do it, you'll have your knuckles rapped very badly. So by the rich countries. If you just think about that slide that Lauren showed about the funding, the assessed contributions only provide enough money to pay for taking the rubbish out and paying for secretaries. It doesn't pay for any programs. All the programs have to be funded through voluntary donations. Anyway, I'm going on. I think we should move. Deepika, what are we going to do for groups? Are we going to reproduce